Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Hello, everybody. It is Tim Clanton from the College of Remote and Offshore Medicine, and I've got a couple of guys that I'm going to be talking to today, who, in my opinion, are some pretty experienced guys that have a lot of knowledge and wisdom to impart, and I'm lucky enough to have them with me this evening. I've got Dr. Tom Mallinson, who's also a member of the college's faculty, as well as Patrick Wenger, who is a new addition to our faculty. But I'll let them tell you a little bit about themselves before we start our discussion this evening on clinical courage. Patrick, tell us a little bit about yourself.
Hello, everybody. Thank you for inviting me. My name is Patrick. Coming from Switzerland, up in the mountains in the south. So started up my medical career field as a ski patrol for 5-6 years. Then I became a paramedic in Switzerland, did my FPC certification, spent some time in Africa and Mali, did my master in mountain emergency medicine, traveled around the whole world, met a lot of good people, good medical professional medical providers. Now I'm sitting here with these great guys and discuss something about the clinical practice.
So where is it you're working now? What are you doing right now?
I'm part-time flight paramedic for Air Zermatt, up in the mountains on the helicopter, doing mountain rescue and critical care.
Isn't it the Netflix series The Horn, where you've got Air Zermatt?
Thank you for remembering this one.
So if any of you out there have not seen The Horn, it's a program I would highly recommend. Give you a lot of information on the air ambulance and Air Zermatt. It's pretty impressive, to say the least. Thanks, Patrick. Dr. Tom, tell us about yourself.
So I started my medical career as a lifeguard, and then I progressed to being a paramedic, and I spent a few years as a paramedic, and then I turned to the dark side and went to medical school, and I spent a couple of years doing anaesthetics, and then settled for Scottish rural general practice, because that allowed me to carry on talking to patients who were awake and diagnosing, which is the interesting part, I think, of medicine. And now I am part of the faculty with Quorum. I look after the year 2 on the bachelor's program. I am a pre-hospital care doctor with the pre-hospital immediate care and trauma team, the PICT team, out of Inverness, Scotland. And I am a urgent care doctor in the Highlands, so a kind of out-of-hours GP type role in the Highlands, and frequently get dragged into academia.
In terms of remote healthcare and remote healthcare experience, we have a significant amount of experience in the room. But in particular, I wanted to focus on a subject called clinical courage, and it's something I've been talking to Tom about recently. That's grabbed my interest. The reason being is I feel that for myself, obviously working in remote healthcare, it's something I can definitely relate to. Tom, could you give us a bit of background on this concept, because I'm not quite sure if I understand what it means.
Yeah, so I'm really happy to. I'm not an expert in clinical courage either, so this is my understanding of it rather than me talking from a point of expertise.
Mm-hmm.
So I understand clinical courage, and I think there are two opposites to clinical courage, or I guess two ends of the spectrum. At one end, there is maverick practice, there is, indefensible practice, it's malpractice.
Okay.
In the middle, there's clinical courage, and at the other end of the spectrum is clinical caution. So I guess at one end, the clinical caution, you're too worried to do something for your patient, you're too worried to stand up for what's right or what your patient needs, and you defer a lot of that to more senior decision makers or to another place, person, or time. So you say, I'm a very simple example, perhaps. I don't think I'm very good at cannulating. I'm going to leave that to the hospital to clinical caution. I'm not going to stick my neck out.
Is that because you're afraid of repercussions?
Yeah, so I think that end of the spectrum, there could be loads of reasons for your clinical caution. It could be justifiable caution. I haven't put a cannula in for 10 years. It's best at the hospital. Or it could be, I've been trained to put a cannula in, but this organization doesn't want me to, so I won't do it. I won't stick my neck out because there could be ramifications. So I'm going to leave it to someone else. Which brings us on to what clinical courage is, because that's the thing we want to talk about.
Yeah.
So my view of clinical courage is when you step up to the edge of your established competencies or current guidelines, and you step just beyond those because that's what the patient in front of you needs. So I guess the classic example is the healthcare provider who's at a barbecue and someone else at the barbecue is choking on a bit of steak, and they think, oh, that person obviously needs a surgical airway. That's the answer to that problem. After your standard back slaps, abdominal thrust. And then clinical courage is thinking, I was shown how to do a surgical airway 20 years ago in my basic training, and I'm going to do it to that person right now, because otherwise they will choke to death in front of me. Even though it's out with your normal scope of practice, it's out with any clinical practice guidelines you normally work to in your day-to-day practice, but you're stepping beyond. So that is the narrow definition of clinical courage.
That sounds like a situation where you wouldn't actually be at work.
Yeah, so I think that makes it a more clean-cut example of clinical courage.
Okay.
So you could transplant that to an oil rig, or you're a medic on an expedition.
Mm.
And same thing, you're around the campfire, someone starts choking, you think they need a surgical airway, but your official skill set doesn't cover that skill, perhaps. But you think I'm fairly competent at that skill, and certainly no one else around the campfire is competent in that skill to my level. So clinical courage is doing the best for your patient, even when it steps up to the edge of your established competency and ability.
So if any of you then had to make a decision to carry out a treatment or an intervention on any patients where you've thought, if I don't do this, the patient will die, but if I do this, I'll lose my job. Have you ever had anything like that, Patrick?
It's hard to tell. There was a certain point that the protocols didn't allow me certain interventions.
So protocols then were potentially going against protocols.
The protocols are a big support, but every knife has two sides of the blade. Protocols are helping for getting it home, and then I did my job according to protocols. I'm safe, but certain protocols cannot take over all the aspects of my career field, of my workplace.
In which case, then, would that mean that you might need permission to do a certain procedure, or issue a certain drug or something?
Yeah, issue a certain drug.
So then what happens if you know what drug to give, but you haven't got any communications? Do you still give the drug or not?
So if I have the drugs in my bag and I cannot call, and this one is exactly know what the patient is needing for and have no other option, it's so many influence on this, I will give it.
You probably give it. Would that be an example then, Tom, of clinical courage? Or
yeah, so hearing that, clearly if you couldn't get your top cover or your senior advice or your authorization, that's very much clinical courage, because you're risking a lot for what the patient needs. As you were saying that, I thought back to when I was a paramedic, and sometimes the very similar thing would be, I knew a patient needed a drug I carried, but not for an indication I was allowed to give it for. And then the clinical courage was phoning and really fighting to get the clinical oversight I did need to legally give that drug. So I'm not advocating that we should be breaking laws or digging ourselves a hole. So equally, thinking back to my paramedic days in London, the clinical courage might be pressing very hard to get someone to patch you through on the phone to the on-call medical director, because you know that you can do something to help the patient in front of you. It's out with your normal guidance. So clinical courage might be to find the right person to authorize it.
Right.
Or it could be it could be the clinical courage to stand up in front of your medical director and say, this guideline that we have at the moment is inappropriate. This is not serving our patients properly. Because that takes courage. There's a risk there, but you're doing it to serve your patient population.
So could you then say, if you saw something that needs to be improved, let's say wherever it is you work, you only have morphine as an option for pain medication, but you, having done an emergency care course most recently, certainly in the UK, I mean, I think pretty much everywhere now recommends ketamine as a first line drug. I certainly know from my perspective, I've taken things forward like that because as a paramedic like yourself, it's necessary to stay up to date. So I know I've been to medical directors before and they said, no, you don't need it.
Yeah.
But standing up and saying, hang on a second, this is what is recommended now as of 2023. It's the most preferred thing. And this is why, and setting out a what's the word, a proposal, I guess.
Yeah, and justifying why you're challenging the status quo, because that's where the risk is, and that's where the courage is.
Do you think we should all be doing that, or should we just go with the flow and kind of do as we're told? What do you think, Patrick?
I think it comes all back to how you got through training, how fit you are in the anatomy or pathophysiology or whatever, the whole setting. And if I have absolutely no idea how the reaction is, so I don't gonna take any drugs but ketamine. I mean, it's proven, and it's ketamine is it the life-saving drug?
I guess it could facilitate you to, especially in your role, if it facilitates your rescue of someone 10 minutes quicker, potentially that's saving life or limb, isn't it?
Yeah, I think standing up for it. Yeah, looking for to speak up before the event happens.
Right. It's prevention as opposed to waiting for cure.
Yeah.
But then it takes an amount of courage to be able to do that. We're not, we're all different characters.
Yeah.
And I guess we all have different stressors and things that we're subject to. And I don't know. I tend to think of it as strength of character.
Yeah,
to be able to.
Yes, it is that, but in the boundary of stepping up to the limits of your knowledge, your practice, your guidelines for the benefit of the patient.
So, at what point you mentioned the word maverick before? At what point does your practice become maverick? Then are we talking about you read something on the internet and then trying it?
So I think that's the risk, isn't it? And I think it's a very interesting question, because where is the border between innovating and progressing your practice, especially now we progress our practice through podcasts and web tutorials and e-learning, which traditionally weren't real learning.
Yeah.
But then equally, traditionally in medicine, it was see one, do one, teach one, which clearly we have moved beyond that. But now if you have watched hours of information, you understand a drug inside out, say you've talked to multiple people that have used it in different settings, you have gained a very high level of familiarity with something, but perhaps without any face-to-face use of it. So I think that question of where is the line between maverick and not, where is that line? I think that's very difficult.
Right.
I think the guiding principle is, are you doing it for the best of the patient? Is your guiding principle, I did my very best, to the best of my knowledge, for this patient or this patient population? Or were you thinking it would be really cool to have an excuse to do this thing?
Right.
Because then that's a morally kind of bankrupt starting point, isn't it? That's a self-serving starting point. But I think it's difficult, and I think that's the challenge.
Because when you wrote a paper recently that was published, correct me if I'm wrong, I'm trying to see where you wrote it. The Journal of Paramedic Practice.
Yeah, Journal of Paramedic Practice.
And in your paper, you mentioned that Clinical courage is the term used to describe the practice of medicine or paramedicine outside one's usual scope of practice or relevant clinical guidelines.
Yeah. So I think, I guess it's very easy to reach for the exciting example, right? The paramedic who gave some ketamine, or the paramedic who performed an amputation. That's the exciting. But I guess the far more boring example is you're the expedition medic, you're on a rig, and someone has urinary retention, and they need a catheter inserted. Right? It's I guess it's potentially life-saving, but it's not high adrenaline stuff. But putting a catheter in isn't beyond the wit of man. Like if you opened a book that told you step by step how to put a catheter in, you're a healthcare professional,
right?
And that's very achievable, but it might be beyond your guidance and your formal training. So that would be clinical courage. If there was no other option. If the option was drive 10 minutes down the road and someone can put a catheter in, then you're only doing it to show off and to serve yourself. You're not doing the best for your patient.
Right. I mean, when I was reading your paper yesterday, one of the things I think that kind of hit home for me was there are a lot of situations, especially for those of us that work in remote healthcare settings like offshore oil rigs or ships, when we're not necessarily seeing traumatic injuries every day. We're not necessarily seeing acute medical patients every day. We have a relatively fit and healthy workforce, but that's not to say people don't get sick and people don't get injured. But when they do, there's usually a large gap in between those patients, in which case we're not cannulating every day, we're not putting urinary catheters in, and we're not doing surgical crikes. But there may be occasion when you might have to do it. But then now, because things are so heavily, I would say, regulated, but a lot of our autonomy now has kind of been removed. We need permission literally for everything. And for me personally, I feel it would take quite a lot for me to, I realize I have to do this because I have no choice. If I don't do that surgical airway that I've not done in however many years, or maybe the only time I've ever done it is in training on a plastic model, I'm worried I'm going to do it wrong.
Yeah. Well, so when there are far more knowledgeable people about clinical courage. There was a paper in 2020 from some Australian folk who surveyed loads of rural medics, and the findings from speaking to these clinicians was key aspects of clinical courage were managing uncertainty. So, do I need to do this? Don't I need to do this? Do I have enough information? Don't I have enough information? And also very clearly knowing your limits. So again, I'm not advocating that we should all go around, performing surgical airways. If the last time you were taught to do a surgical airway was 20 years ago and you don't remember it, that's very much it would be a bit of a maverick thing to do one.
Right.
Whereas if you were trained last week in high fidelity simulation in a simple approach to surgical airway, and you walk out that classroom and someone needs that doing, clearly that's very different. You're knowing your limits. You can think, well, I've just practiced and I've done 20, and this person needs it, and if I don't do it, they will die.
Right.
I think that's that challenging spectrum of.
So, would you say clinical courage is then a common thing? Does it happen, or is this part of a normal daily decision-making process when we're doing medical work? What do you think?
I know what I signed up for, so I knew that the life as a paramedic, also in the mountains, or on the helicopter, or some remote, you're walking always on the edge.
Does that mean then it's more applicable to lone practitioners, as people that are on their own that are having to make high-speed decisions?
I mean, it's always better to have a team around.
Right.
When you have a single paramedic job, role, then your preparation mentally is different than when you work in a team. But sometimes you get a team, you make the best out of the team, looking for the whatever strong sides there are and pushing them to on this side. But when you signed up on this role and you agree to responsibility. What's responsibility? It's a capability to respond.
So are we saying then that you should be prepared as a normal thing? If you're going to be a paramedic or you're going to be a remote healthcare practitioner, you should be prepared to put your license or your registration online for the benefit of the patient.
I think it's challenging. The more I'm involved, the more my career progresses, the more I think that all paramedics and similar aligned roles demonstrate clinical courage on a daily basis and is then in their normal work. And I think part of that is a cultural reluctance to phone for help and to discuss cases.
Okay. Because they're embarrassed, or?
I think there are multiple barriers to that. So there's logistical barriers. The phone doesn't work, the radio doesn't work. My organization doesn't employ anyone as a senior clinical advisor. I think there's the embarrassment for asking for help. But also a lot of the situations in pre-hospital care don't meet any guidance. You can't write guidelines for everything. So I would suspect a high proportion of the workload on a rig as a rural medic dangling off a helicopter with Air Zermatt, I would suspect there is no guideline that 100% matches what you're doing. And every time you are practicing in that area beyond, outside, adjacent to guidelines, you are undertaking clinical courage. And some things are more courageous, some are less. Some are, I think the best way of getting this person out of the house is to do this.
Right. There's
no guideline for that. I think it's the best thing to do. You could argue that anytime you take a patient out of a house, there are safer and more to the letter of guideline options. Like, I could phone for 5 other people, and we could each take a corner of the stretcher each, and we could have one person walking ahead and one person walking behind, and that would be much safer. But we're going to do what we think is best for the patient, which doesn't align exactly with guidance. So I think in pre-hospital care, mountain rescue, you are often demonstrating clinical courage in daily practice.
So would you say then that it's a common thing for maybe people to step outside of guidelines and then not say anything about it?
I think that's definitely the issue there, that culturally, if things aren't seen, they aren't necessarily written down. If you've done them for the best of the patient, no one's come to harm, and it was stepping outside your guidance.
But isn't that just getting away with it?
Yeah, I think getting away with it is a way of discussing either clinical courage or maverick behavior. And the challenge is knowing which is which.
Because I imagine there would be a reluctance to say anything. We just do it in the hope that maybe everything works out. But then why wouldn't people say anything? What are they so worried about? Is it losing their jobs, or are they going to lose their licensure, have to go and be retrained, or is there? What's the biggest concern? What's maybe stopping people going, hey, I don't think this guideline or protocol fits my current or our current scope of practice and needs to be extended. I would like support in that. I mean, I guess putting that argument forward is an act of courage, is courageous in itself. Yeah. But at the same time, I mean, again, I can only look at it personally, I think, in that there are definitely occasions when you would be worried that you're going to be branded as a troublemaker, or, again, that term maverick, even if it wasn't necessary, you weren't acting in that manner, there's a concern that somebody else views you that way, which is different than how you might view yourself.
I think it's multifactorial why people wouldn't want to raise their head above the parapet. I think, without getting into it, because it was a much better talk that you should all go and listen to, the John Hines talk about crack the chest and get crucified, where the late great John Hines talked about thoracotomy. That was a talk on clinical courage, but he called it something else. and that was talking about the repercussions of doing something which appears extreme for the benefit of the patient,
Right.
and the backlash you would get.
Okay.
And his argument there was, you should do this because it will save a patient's life, even if you get flack for it later.
But then was that because it was a controversial subject at the time, and there were other people that believed doctors or whoever shouldn't be doing that at the roadside?
Yeah, so I think it's controversial, but also some things caught more backlash because people think you are doing something inappropriate, perhaps. But again, it comes to, were you doing something sensible? Was it in the best interest of the patient? Were you an appropriate person to do it? Was there a lack of a better option?
Mm-hmm. That's interesting. The fact you say about a lack of a better option.
Yeah.
You're the decision maker on the ground at the time. And if you haven't got the support and you haven't got the backup and a decision has to be made, it's like the load and go or stay and play.
Yeah.
It's down to you, I guess, at the end. I don't think it sounds to me there's no clear answer.
Yeah, and I really do suspect, like, so Patrick, when you're on the mountainside,
yeah,
I suspect every rescue doesn't align to the policies or protocols of how to perform that rescue, because you do what you need to do to get the person off the mountain as you feel is safe.
So I always ask, what's the goal and what the patient needs and what's the end treatment and what's a team or what's my part, not my ego. It's not my ego, it's the part, the duty I have to fulfill. I'm the guy who's just running out the back, taking care about the helicopter, and the guy who's responsible for the patient or just for the safety. Take over, step in wherever my knowledge, my experience is needed. So what's the goal? Bringing the patient finally to the surgeon, bringing to the hospital.
Yeah.
And the factors you told many times about factors you can do in trainings, but outside the factors are different. Are you rested enough? If you are hungry, the weather, you can always blame the weather.
I think we do that a lot.
I mean, the best thing to blame something is the weather. Mountains, you always can blame the mountains. You can blame how deep the snow was, how dirty it was. Finally, it comes all the end. Can I get this? I have to put it on paper. What happens? Do I need to go out of my protocol or? Sure.
So if you do need to, make sure you document it.
I have documented, yeah.
Yeah. And so you can maybe later on justify your actions to someone who thinks that you should not have done that.
Often I'm not alone, so if we are three on the mountains, three of us see the same conditions, maybe a little bit different, but weather is bad. It's the decision we made so far. When we went in, we had the patient, and there were maybe two options: stay there for a couple hours, or just take him, do whatever needed to get him at least to the helicopter, or ambulance, or boat, and bring him to the appropriate situation. But if you have the factor that you have to stay there for a long period, and you're there, limited resources, that's another factor. A lot about the factors, and for me, especially, factors are common.
So are you saying for you, because you've got team members with you, that process is easier in terms of if you get to a point where you feel, you know what, this is in that gray zone, whether, you know, I'm kind of damned if I do and I'm damned if I don't, but at least you've got someone you can turn to who can maybe back you up or say to you, actually, that's probably not a good idea. Because I guess for you, safety is a big thing, especially if you're winching or doing some kind of rescue, which is complex enough, you know, in itself. You know, there's no good going down into a crevasse, I guess, unless you've got all the protection that you need. But you still want to go and get that patient, because if you don't, you know, potentially they're going to die. But you've got supportive teammates. So having courage is better when you're with a group of people who, or your peers, who will support you as opposed to being on your own.
And you said there the key point of it's not about your ego.
I know. I wrote that down. Yeah.
That decision isn't driven by your ego to do
Right.
something cool or something exciting. It's driven by the best for the patient.
Right.
So when you justify it later, you know in your heart and you know very clearly from the clinical situation that your decision wasn't driven by your ego. It was driven by this is what the patient needed. And to the best of my knowledge, this was the best option to offer them, even if it wasn't aligning directly with guidelines or policy. And clearly with guidelines, they are guidelines. They are
They're there for a reason.
protocols. But yeah, I think that was the key point. It's not about ego, it's about the patient. The patient is in the middle of the decision making.
Yeah. I mean, I made a note at the same time, as soon as you said the word, not letting your ego get the best of you. You've got to be humble. I think you've got to be honest with yourself. And Tom, you mentioned about you knowing your limits, knowing your capabilities, knowing what you can and what you cannot do. And there may be occasion that's grey, and you have the knowledge, and potentially you have the ability, but maybe it's the first time you've done it, or you haven't done it for a significant period of time. And if you don't do it, then potentially, you might lose a patient, which nobody ever wants to do on their watch. But at the same time, potentially you're open for criticism, especially again by your peers who say, who does he think he is, doing a surgical airway? Nobody's done a surgical airway in 20 years in.
Yeah, that's exactly it. And it's very easy to use the surgical airway as the example.
And I know, because it sounds like it's an extreme thing.
No EMT has done a catheter. Why were they doing a catheter? You think, well, what were the actual situations? Were you snowed in a clinic, no one was coming to get you, and that patient was in acute urinary retention, and you phoned a doctor and they talked you through doing it? That's a very different story.
As a doctor, if you were doing topside medical cover, so say I'm the medic on the oil rig, and at 3 a.m. I get a knock on my door. One of the night shift guys comes in and says, "Oh, I need to see you. I've got a really sore throat and a cough. I can't sleep, or I don't feel very well." So obviously I get up. It's 3 a.m. Obviously I'm a little bit groggy. I've maybe had a long shift the night before. I examine my patient. I take his temperature, I take his obs, I listen to his chest, I can hear some, congestion. He's got a bit of a wheeze and some crackles. He's got a little bit of a temperature. I'm pretty happy that there's something going on there, and he's, maybe got a chest infection. So I'm relatively happy in myself in that, some amoxicillin or something similar for a respiratory tract infection would be appropriate. In which case, there's an expectation possibly that I will phone you at 3 a.m. in the morning.
Yeah.
Would you appreciate that call? And it's a difficult one, because what if you've been out on your basics team or whatever and you didn't get in till 1 a.m. and then you're starting your GP service back at 7 or 8 o'clock in the morning, and some medic phones you up from wherever and says, "Can I have permission to give my patient some amoxicillin because he's got a chest infection?" Are you going to appreciate that? Or, on the flip side of the coin, knowing that an offshore medic should be perfectly capable of making that level of diagnosis and competent to prescribe that level of medication, and it would be appropriate to maybe leave it until the following morning. But obviously our protocols don't necessarily say that. They say that for every antibiotic that you have to issue, you must get permission from your medical supervisor. But that could be any time of the night. And personally, I kind of struggle with it because, I know the likes of yourself, I know there are loads of jobs that you guys do. You're not just providing topside cover for an oil rig. You've got your normal maybe GP hours or your emergency care hours that you have to fulfill. Would you appreciate me calling you at 3 o'clock in the morning? Because if I feel you would, because I guess I've kind of been in your position, and I've experienced this. It's like, well, why did you call me for that? I've had that feedback, which maybe has implanted a scar and has put me off doing that, and I would rather wait until the following morning. But then I'm going outside of protocols.
So
Is that maverick? Is that courage? Is that...
So I think that is a difficult question for me to answer. So to answer your question about how I feel about someone, that phone call. So I occasionally get a phone call as a basic Scotland responder or in different roles for that nighttime phone call. I make a concerted effort, and maybe if someone listens who has phoned me at 2 a.m, they can disagree, but I make the concerted effort to listen, accommodate, and try to be as helpful as possible at 2 a.m.
Right.
Even if I'm thinking, why did you wake me up for this? You are more than capable of dealing with this. There is a reason they're phoning me at 2 a.m.
Right.
It might be because they didn't want to step outside their protocols or guidelines. That's fine. It might be because they are uncertain about the decision and want support.
Yep.
It might be because they are on the edge of their protocols and they're stepping into that grey area of clinical courage, and I'm their safety net or double check.
Yep.
So I make the conscious effort to actively give my best to those phone calls, because it's very easy to be grumpy and annoyed at someone phoning. If I think that phone call was particularly ridiculous, and I think, this is within your protocols, your handover was so clear, you knew exactly what this patient needed, I really am not sure why you're phoning me, I will try to put that aside at 2 a.m. and just answer the question and deal with the issue.
Yeah.
And then ideally at a later date say, why did you phone me at 2 a.m?
Right.
Like, you're a really good paramedic. Why did you phone me to discuss that case? And often when I do that, they say, I know I knew exactly what that patient needed, but because of X, Y, and Z, I wanted to run it past someone else, or I wanted to safety net that patient. So I was really just phoning you to do something else.
Yeah.
But I try consciously to never be annoyed or push back too much at 2 a.m.
I guess we're dealing with human beings, and human beings have different feelings. Everyone's, different. Unfortunately, not everybody is as accommodating, and I'm sure there's, a few of you guys out there have had the same experience. But at the same time, I think what you're saying, Tom, is what we must ensure as individual practitioners is the safety of our patients ultimately.
Yeah.
And you said the same, Patrick, ultimately that is our responsibility, is to the patient.
And I think that's why the 2 a.m. phone call isn't the time to discuss the ins and outs of should you have phoned me.
Right.
Because
fair comment.
Because 2 a.m. is the time to ensure that patient is 100% safe.
Yeah. Right.
And then later you can have a discussion of.
So again, guys, I don't know if you've ever been in that kind of situation, but I guess the courage is also not being afraid to make that call.
Yeah, exactly. Yeah. Because sometimes the clinical courage is I'm going to wake up the consultant at 3 a.m.
Yeah.
That's clinical courage as well.
Right.
Or I'm going to take this patient to a major trauma center because I think that's what they need.
Right.
Or, it might be not the closest hospital, or it might not be a definitive diagnosis, but it's taking the risk of annoying someone for the best interest of the patient. It's risking that 3 a.m. phone call to someone because you aren't sure. And once you're, that's knowing your limits, and that's managing uncertainty. Yeah. So sometimes I've found my limits. I'm very uncertain what to do. I need to phone for help at 3 a.m.
Yeah.
Which is clinical courage, because you're going to get backlash from some senior medical decision makers. Which isn't pleasant, is it? So that's clinical courage as well.
Yeah.
It's less.
But maybe again, as part of that honesty, is recognizing your limitations, but also recognizing a training need. Actually, I now need to go out and read up on this, or I didn't do it, and I didn't do it because I felt I didn't have the knowledge, or I didn't have the skill to be able to do it, but then seeking out as a consequence of that situation.
Yeah, I guess the putting your hand up afterwards is the clinical courage bit.
Yeah.
But it's it's challenging. It's a very nebulous concept, and that's why some of these other much more knowledgeable authors who have really looked into what clinical courage means to different people are bringing up some really interesting ideas and viewpoints and perspectives on it.
I mean, I think for yourself, Patrick, in terms of kind of courage, it takes courage to get in an aircraft, a rotary wing aircraft, and I don't know what the elevation is of Zermatt off the top of my head, but that in itself takes courage because you know you're already going into a dangerous place in order to practice medicine and, you know, locate somebody and then try and you're going knowing that you're going to an extreme environment, but you're still going to do your job. And you're going to do your job to the best of your capabilities. That in itself takes in my opinion, a significant amount of courage, not only skill and knowledge. So I think there are certainly people, maybe a little bit like yourself, that you work at extreme ends of this spectrum, and I guess there is a spectrum to it. Myself, I'm certainly not going there on a daily basis, and you're having to make high-speed decisions, not only based on the environment that you're having to work in, but at the same time, you might have to omit a treatment for a patient because it's just not safe to stay. And I guess that's where that stay and play and load and go situation comes in. Because arguably, if you stayed, potentially you might not come out. And you may omit a treatment. So on the flip side of the coin, rather than giving a treatment, you might not give the treatment, again, for fear of the consequences. But then that consequence could be a crevasse collapse, or I don't know, or something, or an avalanche. So I guess it's a grey area. It seems quite fuzzy.
I also think it's when you will ask me the same question 10 years ago, I will completely act different. But I made it with good people's, always most time with the right people's, through many storms, and you get to prove the storm. And where the growth is, it's mostly you growing when you have problems and you're solving it. So I think it's also part of how many storms or whatever treatments you did. How deep are the root of your personal character?
And that, because every weathering a storm is going to have a degree of clinical courage. Because it wouldn't be adversity, it wouldn't be a storm if it was easy and it was just following a guideline and it was doing A, B, C, D, E. It's weathering a storm because it's difficult and you had to do the best for your patient in the face of difficulty.
I think at the end of the day, we're advocates, and we've assigned ourselves that role, and we're advocates for our patients. And I know it kind of might sound a little bit crass, but you know, that's why we're here. That's why we're doing the job that we do. So there's a certain, you know, something to our character that puts us in this position in the first place. But at the same time, it's realizing that job is not always going to be easy. There's going to be times when you're going to have to make difficult decisions.
Grey area decisions.
Grey area decisions, where the outcome could be good, but the outcome could be bad, especially if it goes wrong. And again, it's having the strength of character, I guess, to support yourself, but at the same time, knowing and understanding your limitations and not being afraid to ask for help, like yourself, turning to your teammates where you've got close support that can maybe back you up, calling yourself Tom at 2 o'clock in the morning and say, unfortunately, I have to call you because my clinical guidelines say that I should. I'm sorry about that. I hope you don't mind. But it's the way we communicate that.
Well, that's leading on to civility saves lives, which is, so that's a big, there's a big push in the United Kingdom for civility saves lives, because if you're phoning the surgeon and you're polite to them, they'll be in a better mood, they'll listen to what your handover is, and they'll perform better at their job. Whereas, you know, if you land on the side of a mountain and you're horrible to everyone who's providing first aid, that patient will get worse care because they'll give you a bad handover.
Yeah, that's true.
But if you land and you're a nice guy and you take your sunglasses off before you talk to them, you know, there's better outcomes for patients. So it's a big push in the UK for civility saves lives, and it's catchy.
but it's true. I mean, it's about a lot about empathy.
Empathy.
Thank you for.
So no.
Yeah.
But empathy with who? With your patients or with
I don't.
peers or
the patient has enough issues, and he went in this whatever he went in. He started the whole process. So, but some kind of now I'm duty. I'm coming here, so he trusts me. Is it always the patient which condition he is sometimes not in best shape, but when he trusts me, so I have to trust my medical director.
And again, coming back to the patient's the center of your decision making.
Yeah,
it's not your ego; it's for the patient.
No.
So do you think then, Tom, that the clinical courage is something we need to be developing, and to what end?
I think first you need to explore it. You need to explore how paramedics, in the broader sense of that professional group, do things that step beyond guidance. And we need to open the culture of being honest when that happens. Because if we don't know what's happening, you can't study it, you can't modify it, you can't make it safer. I think that's the first step. We need to study it and look at it and talk about it as a concept.
Right.
And then you can start exploring the foundation of the difference between clinical courage, doing the best for your patient in a safe and appropriate manner, versus people who are just throwing the guidelines to the wind and doing whatever they want. They are completely different. But I think currently, because we don't talk about the concept, it's hard to differentiate the clinically courageous who are going above and beyond for their patients and those who are bad practitioners who are putting their patient at risk. But until we talk about it, we can't delineate those issues.
So by bringing clinical courage, to the fore, into the light, for us as paramedics, then the next step is continuing to expand our autonomy and recognizing that we have a certain level of knowledge. There's an expectation now, to be on the HCPC, it's a degree level qualification, certainly to be a paramedic anyway, and then developing our autonomy by others recognizing our capabilities, but speaking out, not being afraid to say, this is who we are, but in the same respect, being honest.
Being honest and realizing that autonomy doesn't mean working alone.
Right.
Autonomy means doing the best for your patient, phoning your medical director, phoning your senior decision maker, chatting to your team on the hillside. Autonomy and being an autonomous practitioner doesn't mean working in isolation. I think that's a big step that we are as a professional body that's improving, but I think that's a key element as well.
Okay.
Because you need that triangulation and that support to know that you're doing the best for your patient and you're not just doing something strange for your patient.
Tom, Patrick, I think this is a fascinating subject. After I had the privilege of reading your article the other day, Tom, it's just like certain things that you've said, most certainly hit home. For any of you guys out there that's interesting, Tom Mallinson is the editorial board member of the Journal of Paramedic Practice. So if you can get yourself a copy, I'm just looking to see if there is a date on here. I've got November 10, 2020 at the bottom of that paper. I would encourage you to maybe Google clinical courage and have a think about it, have a think about how it affects you as a practitioner, and ultimately how we can develop that to help improve patient care and clinical outcome. So again, thank you very much, Tom, for your time this evening. Thank you very much, Patrick, for your time. Have you any last words? Anything you would like to mention I might have forgotten?
No, last words sound very ominous. No, I don't have any final comments.
No final comments. Yeah. Anything from yourself, Patrick?
No, you told the last words. That I think we finish up. Maybe. So when I need to call, I call my medical director. It's 2:30. At the next call on 3 o'clock, 3:30. If I don't call, he don't recognize the issues we have on the front line.
Yeah.
When I make a proper overhand report. And if I'm not able to make a report and say, hey, that's one is the problem, I'm looking for this, can you support me or not? Then it's my fault. But if I can make a proper report and recognition, I think it's coming from us, not from top. Down to top and top to down. It's not only one side. We also have to prove that we are capable to doing it. And call whenever we need call, and if we have no cell phone call.
Which is clinical courage, isn't it? Advocating for your patient.
Advocate for the patients.
The core to clinical courage.
Again, guys, thanks very much. Thank you very much for listening to the Co-ROM podcast, and I look forward to the next time that we'll have a meeting. Goodbye for now.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Corum, COROM, corum.org.